Hello, everyone. Uh, Welcome to the Clinic Talk podcast. My guest today is Dr. Raymond Cho. He's the president and lead psychiatrist of Houston Mind and Brain. Dr. Cho is board certified psychiatrist with 27 plus years of experience in neuropsychiatry, cognitive neuroscience, neurostimulation therapies, including TMS, which stands for Transcranial Magnetic Stimulation. He's the only psychiatrist in Houston area to receive federal funding for TMS research, recognized as the leading expert in the field. He received his medical degree and master's degree in neuroscience from the University of Toronto, completed his psychiatry residency at University of Pittsburgh and advanced psychology training at Princeton University. He's a prolific researcher that published in Science, Nature, Neuroscience, American Journal of Psychiatry, and more magazines. And then he was the former chairman of Schizophrenia and Related Disorders Alliance of America. Welcome to the show, Dr. Cho.
I appreciate the kind invite and looking forward to our discussion.
Likewise. So my first question for you, when did you decide to become a psychiatrist? What actually inspired you to become a psychiatrist?
So that goes a ways back. When I went to medical school, I had a longstanding interest in the mind and brain. Actually, I just realized that, that might be the origin story of our clinic name, Houston Mind and Brain. But within medical specialties, that really meant either psychiatry, neurology, or neurosurgery. And I did explore each of those pathways in earnest. But I think what really struck me in psychiatry specifically was the interesting psychopathology, and then also the human side of things. So one particularly sort of seminal medical elective that really sealed the deal, so to speak, was in an outpatient psychiatry clinic in Toronto when I was, rotating through the various rotations. We saw a lot of schizophrenia patients, a lot of homeless patients. It really struck me how, the very things that most of us take for granted every day, how we perceive the world, what we believe in, how we behave, treat each other, all that, we take for granted. And when you see all these things kind of break down and not work properly, at one level, it's extremely fascinating because we do take these things for granted. On the other, much sadder, more unfortunate side, there's the human toll, and it was heartbreaking in many cases to see sort of the functional decline that many patients suffered. So I guess both out of sort of fascination, intellectual curiosity, but also, to put it simply, wanting to help people. So I think psychiatry really married those two goals, and especially after that elective, my decision was made.
Okay. And then just to clarify, so what year was Houston Mind and Brain established?
It was late 2019.
2019? Okay. Okay. And you, were you the sole founder?
I was, yes.
Okay. Very good. And then would love to talk a little bit about neurostimulation therapies. Can you tell us more about TMS and how it's utilized in your clinic?
Sure. Yeah. So as you mentioned in the opening, it stands for Transcranial Magnetic Stimulation. The transcranial just refers to the fact that the magnetic pulses are going through the skull and uh, hitting your brain tissue that way. The magnetic refers to the form of energy being magnetic. Ultimately, that induces electrical currents changes in the brain that lead to either increased excitability or decreased excitability, depending on what you're trying to achieve, um, and then stimulation. So, um, when I was primarily in academia and doing a lot of research and also trying to disseminate really good therapies like TMS. I was particularly struck by uh, a couple things about TMS. One was just that it was so novel. Um, Most of our therapies that we have at our disposal in psychiatry, at least as an MD, are really these days just standard medications. Um, and here was a brain stimulation technique, very different from ECT or so-called electroshock therapy to many. This was a very safe, non-invasive stimulation technique that could be administered on an outpatient basis. It didn't involve any additional drugs. Very safe and well tolerated, and importantly, highly effective. Um, Patients that have gone through the very frustrating journey of trying multiple medications, and either them not being effective or only partially effective, or suffering from the many potential side effects, arrive at our clinic and uh, are sometimes even tearful, thinking, "Oh wow, there's this novel therapy that can be very effective." So I'd actually started the TMS clinics at various institutions that I worked in the Houston area, UT Health, Baylor College of Medicine, the VA hospital, and saw countless numbers of patients get better on TMS therapy, mostly for depression. The FDA indications are for depression, OCD, and smoking cessation. So primarily, most of the patients we treated were suffering from major depressive disorder, and having seen, uh, personally, countless patients get better with TMS therapy. When I started the clinic, I thought, that really should be the central focus, since it's. I saw the efficacy. I saw people's lives turn around, and I suppose we may get to these topics later in our discussion, to have an outpatient practice that is fiscally, financially viable. Something like TMS can also be helpful in that regards.
Yeah. Thank you. Thank you. And in terms of challenges, what were some key challenges of bringing this treatment to the clinic, if any?
Hmm. Uh, there were many. So I'd spent many years in academia, and I think I was pretty decent at what I did in academia. I did a lot of teaching and clinical work, and the mainstay of my activities centered around research. So built a lot of knowledge and skills through that whole process. It definitely did not completely prepare me for a community psychiatric practice, um, which obviously has a lot of business aspects to it, but even in the practice of psychiatry can be somewhat different from those clinics in an academic setting. So, um, unless I inadvertently missed those classes, we didn't learn about selecting EMR systems, how to submit billing and claims, and collecting payments from patients. Um, For a while, I was the IT guy in our clinic. Thankfully, I'm not the IT guy anymore. But anyways, everything that you take for granted when you're working in a large academic setting, you quickly learn what the gaps in your knowledge and skill set are. And yeah, no one that starts a new clinic by themselves is going to have a large team. I literally had a staff of two. So we had to figure out a lot of things on our own, get advice, do some research. So yeah, setting all the little moving parts, and as you know, that there are many, um, that was quite a process. So I think I knew not to be so naive to think that I could just rest on my reputation as an academic, as a as established researcher and clinician in the Houston area. And yeah, I think I was sort of intellectually appreciative that that wasn't enough, but I did also maybe hope against hope that, if we build it, they will come. And initially they came very slowly. And so I also had to learn about marketing and advertising and put our name out there too, to have the visibility.
That sounds very familiar to me. I'm sure our listeners could definitely relate to this. The ones that open clinics or, looking to open their own clinic. But in terms of challenges related to TMS, do you hear a lot of pushback from patients when you offer TMS treatment to them?
Uh, Less and less. Yeah, so I started some of these clinics that I mentioned in the Houston area soon after I arrived in Houston, which was back in 2014. So even just over the last 10 years, I think I've seen an evolution in the awareness, the acceptance, that the knowledge about the details of TMS. Clearly, there still has to be a lot of education. Patients might have heard of it, or they just first read about it on our website, and they'll come, having to be educated, and their hands being held through the whole process. But I'll say over time, the kind of resistance, the challenges would be to sort of quickly um, kind of disabuse them of the notion that it is shock therapy. So brain stimulation and popular media, the old movies, kind of gets a bad rap. There's pretty gruesome images through many TV shows and movies about what brain stimulation looks like. I'll say that even ECT, electroconvulsive therapy, which is more commonly depicted in movies and TV shows, even that has evolved considerably over the past number of decades. And I think it's a very viable, and especially with respect to or compared to many decades ago, even that's a safe, viable option. That said, TMS, different kettle of fish. We are stimulating the brain, but as opposed to ECT, we're not actually wanting to induce seizures. We want to avoid seizures. The mechanism of action doesn't involve a seizure. So these kind of critical distinctions are something that we have to cover um, pretty quickly in those patients that express initial concerns like, oh, I don't want to be shocked in the way that they conceive that they would be in movies they've seen. So I think, yeah, as I said early on, 10 years ago, even 5 years ago, I think I was encountering that kind of resistance more commonly. I think, I guess, to the credit of the field, or just patients being better educated about these procedures, I'm actually encountering that kind of wariness and concern, much less so. Um, and then we have the more, I guess, more fruitful discussions about the details of the protocol. Still have to talk about safety and efficacy, but at least sort of the potential heavy lifting of saying it's not shock therapy, if that's increasingly becoming a thing of the past.
Yeah, I was curious because I figured there'll be definitely pushback for those patients that are less educated, maybe connecting this type of treatment to shock therapy that they've seen in the movies, as you mentioned. Um,
Mhm. Oh,
thank you for this.
I might add one thing. Curiously, sometimes some patients will actually see TMS as being more natural a therapy than medications. I think medications, that there's a lot of very good medications, and properly prescribed to properly diagnose patients. And if it's well tolerated, it can be also very effective. Um, but for whatever reason, some patients that come to us think that medications are not natural, whereas TMS seems more natural. So somehow that's more attractive. I think at a practical level, the tolerability, meaning lack of side effects, that may actually be a bonus of TMS. That there are a host of medication side effects that are commonly encountered, unfortunately. TMS, it does have potential side effects, but generally it's very safe and well tolerated. So, if anything, perhaps sometimes uh, uh, because of misconceptions about the nature of uh, TMS and whatever you're doing, it's still some external thing that's being applied to the brain, whether it's medication or magnetic energy. It's still something sort of unnatural being artificially applied to the brain. That said, TMS is a very safe and well tolerated
Yeah.
therapy.
I mean, I'm assuming it's the stigma sometimes behind the medications, and then maybe the side effects of medications that people may be concerned about, that maybe are looking for
Yeah,
alternative.
yeah. Yeah, I think there's historically been broadly a stigma, and not even just psychiatry. If you go far back enough, other medical types of medical illnesses. For those that are older, they'll probably remember the stigma around cancer. So even that was kind of a taboo subject if you go far back enough. Mental health still has stigma around it, unfortunately. Although I'd say that that's slowly getting better. But part and parcel of that was the the stigma attached to taking medications, and perhaps TMS and other alternative therapies, including things like ketamine therapy, which itself is a drug. Perhaps those are seen as different enough that they kind of escape that kind of stigma that's attached to more traditional medications.
Yeah, yeah, makes sense. Makes sense. Thank you. And Dr. Cho, so many physicians with your experience and academic background, you know, they don't go into private practice. How do you balance clinical care, business operations, innovation within Houston Mind and Body?
hmm Mind and brain.
Sorry, the mind and brain.
That's okay. Uh, yeah, that took some figuring out, especially when we were in our beginning stages in a small clinic. It, you do have to see patients uh, because of the demands and to keep the lights on, so to speak. But if I'm also the IT guy and the computer systems are down or there's something wrong with the EMR, that also has to work to be able to see patients and so forth. Um, Thankfully, we've had some considerable growth over just the last few years that, yeah, I think there can be um, a very helpful division of labor. And so, yeah, I guess there's a common notion of being able to work on the practice, not just in the practice. And I think I've increasingly been able to spend more time in working on the practice, in program development, bringing in novel types of treatment, um, and working on workflows and SOPs, etc. Yeah, so I think part of it's sort of a permissive thing. I have more time now to be able to do that. But I think it still has taken at various juncture just being intentional about doing that. I still am very much involved in clinical work, and especially in more specialized cases where my particular expertise and background needs to weigh in. But I guess been better at learning to pick my battles, so I might dedicate my clinical work primarily towards those specialized cases, whereas the rest of our clinical team, who themselves are extremely competent, can maybe attend to more of the sort of bread and butter cases in the clinic.
Yeah, yeah, thank you. And how do you? I mean, I like asking a question when. How do you split your uh, schedule between clinical work and then operations work? Is there like half and half, or is it mostly you're on operations now? How would you describe it?
Yeah, it does vary from week to week, but I think on average it'd probably be something like 2.5 days of clinical and sort of direct care time. Um, it's hard to say or define in terms of, I have 3 half days of clinic. Because it doesn't really parse out that way. And that's in part because of the nature of both TMS, how we've just started a new ketamine-related treatment program, which I can tell you a bit more about if you're interested. But things that might need my attention throughout the week, and that really is contingent upon the particular scheduling of the patients when they need, for instance, a motor threshold for TMS. That's a specific type of measurement that we have to make for TMS patients that determines the intensity and location of the stimulation protocol, and that has to be repeated at some regular interval. So, um, because of the variability and when patients need those type of measurements, when I might be needed for a ketamine appointment and adjusting the doses, uh, that can't happen in a sort of well packaged, compartmentalized portion of my schedule. So those are kind of sprinkled out throughout the week. Uh, we have a clinical team, 2 nurse practitioners, another MD psychiatrist, um, and a couple therapists. So there's ongoing sort of ad hoc meetings on particular clinical cases. So if I need to do that, that again is kind of random and unpredictable throughout the week. So
Sorry, yes. The clinical meetings are not scheduled. You guys have them kind of scheduled randomly depending on cases that come in.
so we have periodic provider meetings. So that means the prescribers, the MD and nurse practitioners, we can't have regular meetings just with the therapist too. What we do have more regular meetings is centered around treatment refractory depression and sometimes related OCD. I think that actually is a very critical regular communication where we review all the patients that are receiving TMS or ketamine. Um, we're regularly consulting clinical notes, sometimes bringing in the relevant clinicians that are providing complementary care. There can be things that interact with the scheduling, and so we'll bring in the front office to join the meeting. So I think whatever it takes. There's a core contingent, myself, a few of the other clinicians, the TMS and Spravato technicians. All of us very regularly meet, basically on a weekly basis. But then we bring in others as needed to make sure everything is running smoothly. As you know, clinical care is not just about getting the right diagnosis and giving the right treatment. The things that can make for as minimally stressful an experience, all that sort of bleeds over into things like scheduling, patient payments. That can be a headache and stressful to some patients, depending on what the situation is. So we want to try to be able to proactively, address all those things so that not just the treatment itself, but the whole experience in the clinic goes as seamlessly as possible.
Okay. All right. Makes sense. Thank you. Thank you for that. And so uh, besides TMS, you advocate for psychedelic assisted therapy. So how do you administer this type of treatment? How do you see it evolving in your clinic?
Sure. Yeah. So we have started with a number of patients to integrate ketamine and psychotherapy treatment. Um, yeah, some people may already be aware that that is a thing. KAP, ketamine-assisted psychotherapy. So the way that we've implemented and are now starting to try to implement more systematically um, is either to have psychotherapy right in the session of ketamine administration. So just to explain to everybody that ketamine, while it's very safe and well tolerated generally, is not without side effects. And fortunately, most of those side effects subside within the session of the ketamine treatment. By regulation, Spravato, which is the FDA approved form of ketamine, the requirements are that you are monitored for 2 hours, um, over which you will you have the chance of developing things like high blood pressure, increasing your heart rate, dissociative symptoms, sedation. So all these kind of things are monitored during the course of a 2 hour session. And if everything is settled down by the end of those 2 hours, then you're discharged. Um, so how psychotherapy fits into that would be usually it's in that first hour that you might feel a little bit more sedated and dissociated if that occurs in your treatment. So not maybe the ideal time to have someone talking at you, and you're trying to respond appropriately. Uh, so we're replacing the therapy in the second half. That said, even um, beyond the administration session of ketamine, the effects of ketamine, as far as being effective at essentially opening your mind or being able to reframe how you think about the psychosocial stressors that you're going through, the problems that you're bringing to the therapy session. That kind of effect appears to persist maybe for 24 to 48 hours beyond the acute treatment. So we certainly have had patients that we try to time the therapy session within that window after ketamine administration.
Hmm. Okay, very interesting. And then just to clarify, the ketamine treatment, it's a nasal spray. Is it administered through a nasal spray?
Yeah, so ketamine can be administered intranasally through nasal spray, intramuscularly, or through IV. Um, Spravato, which I mentioned, is just one form of ketamine. It's a chemical. It's a version called S-ketamine. So just to quickly educate the audience for those that are that are unaware, there's two chemical mirror image forms, something called S-ketamine. So if you saw the molecule look something like this, there's a mirror image form that's called R-ketamine. So the FDA approved form is just the S form, and that's administered intranasally. So we have successfully treated many, many patients using just that S-ketamine FDA approved form. There's something called racemic ketamine, which involves both the forms, so the S and the R form. And that's what people that may seek treatment at an IV ketamine clinic will be receiving. Um, that can also be administered IM or intranasally. So we've opted to adopt the intranasal form of the racemic ketamine also. Um, the nice thing about racemic ketamine is that it appears to be a little bit more effective than just the S-ketamine and may have longer durability. So if you do improve, the effects may last weeks to months even, as opposed to S-ketamine, which may be more on the order of sort of days to many weeks.
Interesting, interesting, and thank you for clarifying this. And would love to dive into operations a little bit. Uh, so running a specialist clinic like yours, right? You need to have robust systems, right? I'm assuming. What systems and processes are vital for running Houston Mind and Brain?
Yeah. So I think having centralized databases for tracking patient progress are critical. So we have shared spreadsheets that all the relevant clinicians and staff can access. We very closely monitor, for instance, PHQ-9s, the standard depression questionnaire, for patients that are receiving TMS. Um, Very clearly marked on these spreadsheets are how many treatments they've had, what their PHQ-9s are, If there's notes about anything that has happened during those appointments, that'll be noted. And so, yeah, with a few button clicks, anybody that needs to access such records, it's readily available and constantly updated. So, for instance, when I'm reviewing progress of a patient receiving TMS during that medication management visit, I'll be able to quickly review and access how the progress has been, even if and that's very helpful because I may not be seeing that patient, every single TMS visit. Most TMS visits are really conducted by the TMS tech, who is very well trained and very competent, and they actually most of the time very built up a very good therapeutic relationship. That said, we do have a lot of patients, a lot of moving parts, and that kind of centralized communication sort of hub is very critical for making sure that um, the relevant information is quickly disseminated and kept up to date.
Thank you. And so I'm assuming you guys use an EMR system that all the clinicians and your administrative staff uses, right? Any other softwares to use for communication within the office besides your EMR, or EMR is the only one?
Uh, the EMR is obviously one of our key sort of hubs, not just for documentation, but incorporated is insurance eligibility checks, billing and claims is done partly through that system. Um, Other types of software, I mean, I'm sure most offices have something like this, but clearly you need something like a HIPAA compliant environment. And so we happen to use Google Workspace, and that has a whole suite of applications.
And this is where you use the spreadsheet you mentioned, right? Through Google Workspace.
Right. Yeah. The spreadsheet. Yeah. Obviously, you need a HIPAA compliant environment for that kind of information. Um, yeah. Maybe this is getting too much in the weeds, but Google Chat is extremely useful for very quick communications between staff, uh, and that kind of communication coordination is essential. Um, We do computer cognitive testing, so we happen to use the Creos computer testing platform. Um, but yeah, other than that, I think at least as far as people thinking about incorporating new software into their practice or developing a new practice, yeah, I don't think there's anything else worth mentioning.
All right, that makes sense. Thank you. Yes, I'm always curious because some uh, clinicians use like communication software, practice management usually is part of EMR, but you did mention, SOPs, creating SOPs. Do you use anything specific for SOPs? If you create any, like I don't know, CRM system of any sort, or do you keep it in the Google Workspace?
Yeah, we've been relatively low tech on that front. Yeah, just in the Google Workspace. Yeah.
All right.
Mm,
Thank you. Uh,
mm.
how do you approach hiring and training, and also managing your clinical and support, clinical and admin staff? Is that what challenges have you faced?
Yeah, I think um I think one of the challenges in moving from academia to a community-based practice was encountering a much broader sort of swath and variability in the backgrounds that people came with, just in terms of experience, education, training, etc. So it can be more of a process. I can get deluged by lots of applications, but trying to find those little golden needles in the haystack can be more of a challenge. Um, in that process, sometimes, or maybe often, just direct referrals from uh, friends, family, colleagues can, be a bit more fruitful. Um, that said, I'll have to say, not we don't have 100% hit rate, but I believe our current team has been very, very solid and very happy and proud of all the clinic staff and clinicians. Um, I think what I would say is uh, the one thing that is hard, maybe impossible to really teach and train in is sort of genuine empathy and compassion. So, uh, if I know what school you came from and what GPA you had, probably you can learn anything that we're going to train and orient you in. Um, and so that I have less problem with and less concern about. I think it's been a bit of a process, but I think now it's sort of very core to what we look for. You can't teach empathy, you can't teach compassion. So sometimes people will have stories of their family members suffering from some mental illness, and that built a special connection to the field. Not that we need that kind of story every time, but that kind of story jumps out and indicating that people's hearts are in the right place. So if there's some sort of very foundational positive motivation for being in the field and wanting to help people, as long as the rest of it checks out, then we can train and orient you to anything, as long as that key component is there. So um, that I can't say. Oh, apologize. I thought I'd turn that all off. Um, for that, yeah, I don't think. Actually, I would say probably getting direct referrals from colleagues and people that I know, that might be a little bit more reliable. Um, we can put on a post to Indeed and get lots and lots of applications. Being able to sort of home in on those particular types of characteristics, that can be more of a process if you go the standard route.
And then you're in charge of all the hires, or you have somebody helping you with hiring?
So in the beginning I was, now it's really primarily, at the provider end of things. We have, excellent, a practice manager and assistant practice manager who do all the hiring, the reviewing of, for all the staff positions.
Okay. All right.
Yeah.
Makes sense. Thank you. I mean, there's definitely still we talked about stigma when it comes to mental health. So, what have you found as the most effective marketing strategies to for your practice, right? And then any specific strategies to kind of decrease and help reduce the stigma in the community for mental health patients.
Yeah. Um, so as far as, maybe I'll speak more broadly about, effective marketing strategies, and then yeah, I'll certainly get to the specifically the stigma aspect. Um, as I alluded to earlier, I somewhat unrealistically thought people will just know me and they'll come to the clinic, and that did not happen. Um, so I think we have tried a number of marketing and ad campaigns. I think there is no way around just having uh, slow plodding growth based on the fundamentals. People just have to have a good experience and then be able to write good reviews, tell their family and friends and other patients that this is the place to go for good, competent, compassionate care. Um, you might be able to be smart about the marketing, advertising, and maybe that'll get some people through the door. But I found that the more reliable, sort of long term way is just that slow kind of growth built on the fundamentals. Um, I think uh, core to that though is also SEO. So I'll be honest, I didn't even know what SEO stood for before I started this clinic. So first of all, I had to learn what that acronym meant. But yeah, thinking about if a tree falls in the forest and nobody's there to hear it, did it really exist? So I think first of all, we just have to let people know that we exist, and obviously the age of the internet, the way to do that is to have good SEO. So I think engaging with a good SEO company and being able to boost your visibility that way is essential. But even if you have good SEO, um, it's countless patients who have remarked to me and other clinicians the reason why they come to our clinic is because of the excellent reviews that they've read about us. And you can really only get excellent reviews if you deliver good care and good service. So in that way, I think it has to be something of a slow process. And yeah, I think there's um, some businesses, some practices who may try to accelerate that process through various means. I think I've been happy with the slower, more organic growth and just having solid, genuine, direct reviews from patients um, that, yeah, I think those reviews speak for themselves, and it has uh, yielded a good ROI, so to speak, as far as other patients actually reading those and uh, believing them, coming to clinic, and having it. Um, I think I can say pretty much without exception that we deliver care and service consistent with those reviews. I think I guess consistent with the idea of just sticking to the fundamentals. We've resisted the temptation to uh, sort of artificially sort of increase volume. We have tinkered with the idea of shortening our appointments, for instance. Having 50-minute checks is fairly common at many clinics, and I can certainly understand the temptation and sometimes absolute necessity. The economics around private practice are challenging to say the least. So I understand the reason for that. But I think just to give one example, we've thus far resisted the temptation to shorten our appointments. And very common feedback, positive feedback that we get from patients is that, oh, this is the first time that I don't feel rushed, or the first time that I felt actually heard by a clinician, and I really appreciate that. So variants on those kind of themes are very regular, and so I think at the kind of expense of somewhat slower growth, I would say I'd like to be able to have a balance between growth as a practice, growth as a business, but feeling that we're doing it all on a solid foundation of delivering good care where people actually feel heard and cared for.
Yeah, that's the best practice. I totally agree with you. And for those listeners not familiar with the word with the acronym SEO, that stands for um, search engine optimization. All right. So, and on that note, do you have a company that does your marketing, or have you had one, or do you guys do it in house?
Uh, Initially, we did it all in house. It didn't work so well. Turns out I'm not an SEO expert, so yeah, we did engage with a company, and they helped us very quickly, and rising in the rankings and in the searches. Um, we have engaged with other companies on the marketing end, um, and I guess yeah, those experiences. Yeah, I can't say that they've been wholly unsuccessful, but I guess maybe that's why I've come back to the slow organic growth aspect and just building on the our success on the fundamentals. So we still obviously do some marketing and advertising, but yeah, I guess I'm happy to say that the bulk of our referrals are based on SEO, referrals from the community. Have a pretty large network of colleagues and hospital systems that we're becoming increasingly visible. I get a lot of referrals that way, just organically. So, yeah, I feel like we haven't had to venture too much. I guess we've tinkered a little bit of making our social media presence a little bit more robust, but yeah, to be frank and speaking with colleagues, I guess even that's had mixed results in their experience. So um, if I feel like we're in a good enough a place that we don't have to venture too far afield to get
Yeah.
even more referrals. Yeah.
Yeah, I mean, you're right. There's nothing better than word of mouth and colleague referrals. Those are the strongest, the best, no matter how strong your social media marketing is, because those are usually considered over lower quality referrals. Uh, Absolutely. And so my last question on the operations side before we move on to the last part of the interview. On key performance indicators known as KPIs, do you run any on a monthly basis? And if so, which ones do you run?
Mhm. Uh, Recently we have not. There was a phase, probably about year and a half ago, where we uh, looked very closely at some KPI candidates. Um, so new patients, patient retention, specifically for TMS, new TMS referrals, completion rates, people that would maybe go on to do maintenance therapy. So just to explain what that means, the initial series for depression is 36 treatments, and then if you have a successful outcome, um, the data indicates that long term you have better chance at not having a relapse if you have some form of maintenance TMS. So um, obviously, that has very important clinical impact, but also can have implications for scheduling and billing and revenue. So um, those are kinds of things that we had candidates to track, and we did track for a while. Um, I think, yeah, basically. Due to certain staffing issues at the time that kind of fell by the wayside. And more recently, we're kind of revisiting these same kind of KPI measures. So um, I think broad brush, our patient retention is very excellent. But I think, yeah, I guess I've kind of yo-yoed a little bit back and forth. To be frank, I'm very much, as my practice manager likes to dub me, I'm sort of the visionary of the practice, and I like to think about novel therapies that we can incorporate, like the recent racemic ketamine that I mentioned. Um, our practice manager, Kristen, she's the one that is very hard nosed about. Well, it has to actually work in practice in the real world. So together we've been revisiting the whole issue of KPIs and maybe more systematically monitoring those outcomes in the business.
Yeah, makes sense. And just to clarify, you don't have any sort of productivity report for your clinicians to generate or monitor a monthly or weekly basis?
Uh, we have monitored those things, I guess, more on a quarterly basis. So we do monitor some clinics, as you probably know, employ something like an RVU system. We don't do that. Um, but yeah, we review something on like a quarterly basis. And mm, yeah.
Makes sense. All right, thank you for that. And um, so a few last questions before I wrap up for the day. So how can solo practitioners and independent clinic owners stay innovative with treatments while also ensuring long-term financial sustainability?
Yeah. Well, I'd say even before actually triggering the opening of a practice, to think very carefully about the whole enterprise. It's not for the faint of heart, and I guess as physicians, we have learned the necessity of tolerating delayed gratification, and there's a lot of delay in that gratification. Um, so I think finding out what it really entails, as much as you can. A lot of things you won't really know till you jump in, but as much as you can to get advice and mentorship for those that have been at it for a while. Um, and I think, especially if you're coming straight out of training, I would actually advise to maybe work in an academic setting for at least a year or two, or even more, just to internalize the rigor that should be sort of self-imposed when you're practicing medicine, and in this case psychiatry. Because once you're out on your own, you're going to be self-regulating, self-monitoring. There's going to be all sorts of things hitting you that have to do with the practice, and then maintaining it as a business. So I think if you want to maintain the core of what you're delivering, which is actually should be really at the very least competent, if not actual compassionate care, I think having those kind of values and standards internalized, it doesn't have to be an academic setting, but that's sort of the air you breathe when you're in academia. So I think that is kind of good training to have before proceeding into the community. Um, as I've alluded to, even that's not enough. Then you do have to take very seriously the business aspects. So learning as much about it, and setting things up properly, before you actually start the practice. Um, I think a sort of mentality uh, that you should probably adopt fairly quickly is to be able to not be afraid to make good upfront investments. And that certainly is applicable to the infrastructure, like a good EMR, a billing claims company to partner with, but perhaps most importantly, your staffing. So I think, especially if if you're the solo practitioner, it may be hard to work on the practice and to see patients and generate revenue. And if you're barely able to make payroll to pay the existing staff, it seems crazy to hire even more staff to try to grow the infrastructure and lay the foundations appropriately. Um, that said, I think getting the relevant expertise in-house in place early on, getting a business loan if you have to support that initial investment, I think is a wise thing. Um, helping Having a team to help you work on the business as well as yourself being in the business. Yeah, if I were to offer any broad advice to think through that aspect carefully, and to not be fearful to make the appropriate level of investment upfront. No guarantees that it'll all pay off in the end. That said, but I think long term, you'll find in retrospect that that could potentially have greatly accelerated the progress.
Yeah, I think this is great advice, and thank you for sharing it. It's
Mhm.
very challenging. Yeah, it's opening your private practice, very challenging, and it's not usually fast as some people might think. So it does require a lot of planning, right, and processes. And one of the things that I see that a lot of clinicians, or I mean, a good amount of clinicians do not do, is setting up processes, procedures, right? Setting operating procedures. They're just figuring things out without writing down the process, and creates problems down the line when you're scaling, because without the right processes, it's really hard to scale. Because then you have to go back and figure out how to, write down these processes now that you already completed. Yeah, and Dr. Cho. So my last question is, what is the long-term goal for mind and brain?
Mhm. Yeah. So I think I can answer that question in a couple of ways. One is firmly establishing a good model with our current clinic, and then to be able to uh, expand through replicating that at other sites. Um, uh, Perhaps somewhat embarrassingly, but I'm happy to share that when we first started out, I was overly ambitious, got a little ahead of my skis, so to speak, and we had two sites. There was only one of me, and I found myself going to that second site insufficiently, and it was just too hard to sustain, so we closed it down. Um, Concentrating on our current site was one of the wisest decisions, and now it's very solid, flourishing, and but I think we're in a at a state right now that perhaps we know how things work, and we can put things into SOPs, and we know the kind of culture we want to nourish, um, and if we can. It's not unreasonable to think that we can maybe replicate that at another site. So one simple thing would be just to expand through having this sort of same sort of model infrastructure and vision expanded to additional sites. Um, I think in the future, we still want to be very innovative and incorporate the latest, greatest, cutting edge treatments. You mentioned psychedelics. As you may know, there's other therapies like MDMA and psilocybin that are being considered by the FDA for approvals, or keeping a close eye on those things. Um, I think as those type of therapies or other, say, neurostimulation techniques um, become approved, those are things that because my background in academia, I think I can well assess um, the potential efficacy, and now as a business owner and a practice owner, can also see the potential financial aspects of that, and the viability. So I think I would love to always offer the best and latest and greatest treatments. But then there's sort of the real world application. So feel like I've starting to build up that experience to be able to think thoughtfully about how to make that transition work.
All right, very good. Thank you. Thank you for your time today. It was very informative, and I think it was a very interesting conversation. And I wish you all the best in your clinic growth, and hope you
Yeah.
help as many patients as you can. Yeah, great. Okay, very good. Um, quick question, personal question. So I have uh, a nonprofit, and I'm a clinical director for. We bring the Ukrainian soldiers for prosthetics and rehab here to New York City. Just kind of my volunteering experience. So a common problem is a PTSD. Have you? What did you find? Have you found any successful solution? Have you ever treated PTSD type of issues, and what have you found to be the most effective, if you have?
Yeah, we'd have quite a few patients in the clinic with PTSD. Um, One of our therapists, he has you may have heard of EMDR. It's a technique. It kind of looks like hypnosis, where you're having a, a stimulus go back deep, tracking it with your eye movements. That's actually shown to be a very effective treatment for PTSD. Uh, we actually just started discussing having an integrated therapy and ketamine treatment for PTSD. We haven't done that yet, but now that this integrated model is becoming solidified and an option in the clinic, um, in fact, even earlier today, I saw a patient with significant PTSD. She will be, patient zero, so to speak, in in engaging with that model of therapy. So, probably.
Sorry, TMS with
Also, ketamine with therapy, psychotherapy.
got it. So ketamine was second.
Yeah.
Got it. Okay.
Um, yeah, in PTSD, as you may know, that there's significant dissociative symptoms sometimes, and ketamine is itself a dissociative agent. So some patients will opt for just getting ketamine without psychotherapy. For PTSD specifically, I just myself as a clinician would only feel comfortable if it was supported and guided by a therapist. So I think in our clinic, as far as these specialized services go, we're going to be adopting that ketamine psychotherapy model.
Yeah, no, that sounds amazing. I mean, I get, like I said, it's the biggest challenge I see for our patient population is that stigma aspect, like coming from like Eastern European. Not for sure. I mean, there's other cultures, I'm sure, but Eastern European, they very opposed to even things like cannabis related treatment for um, sleep disorders. And the ketamine is, I think, I brought it a few times as an option, and it was like very kind of, it was looked at as a little, crazy for offering that option. So,
Yeah, it's yeah. I think yeah, maybe ketamine has potential stigma, a different kind, but similar to how TMS has electroshock or electroconvulsive kind of hanging over. Ketamine has the history of recreational use, so it can be kind of a party drug or a recreational. Um, and it's also known as a serious drug because it's actually used as an anesthetic. So, like, why should I be taking this thing that, these druggies are taking or that people use in the OR for serious surgeries? So it does take some upfront education to, disabuse them of those notions
yeah,
and that kind of baggage. Um, but yeah, I think the the model that I commonly adopt when explaining any sort of psychiatric treatment is I guess, the medical model, and thinking of hypertension or diabetes as examples, both chronic conditions, just like most psychiatric disorders. Um, and if you treat the diabetes, if you treat the high blood pressure well, there's going to be some minor inconvenience. You have to take insulin or pop a pill every day. Um, and that, that's a minor nuisance. But if it controls those conditions well, then you can get on with the rest of your day, the rest of your life, and what life is really about. If you don't attend to those, the complications of diabetes and hypertension can be absolutely horrid, sometimes fatal. So, um, yeah, then if you put it that way, the choice is easy. If you don't take care of PTSD or severe depression or a severe anxiety disorder or severe OCD or psychosis, the consequences can be absolutely devastating.
absolutely.
If you attend to them very well, again, there can be some minor inconveniences associated with treatment, but well controlled, you can get on with the rest of your life.
Yeah, yeah. Thank you again. It's great speaking to you, and I hope to talk to you in the future. All the best.
Yeah. Yeah. Likewise. Thank you. All right.
Take care.
Take care then.